said, look, we've had a pandemic. We're going to try and deal with it as best we can. We're going to have to help the elderly, help the vulnerable, help them to shield, keep them safe, and everyone's going to have to follow some basic rules. But other than that, we have to just get on with our daily lives. Treat us like adults, and we will do the right thing. Right now, let's talk to my first guest of this hour, and that's Dr. Mike Yeadon. We've spoken to him a couple of times already on the show since the pandemic. He's the former chief scientific advisor with Pfizer, and he has identified for us a number of issues with the testing regime. Now, Mike, when we've spoken before, the big thing that lots of people are asking the government about, and I saw this on all the Sunday shows again, is how many people are getting tested? Why aren't we doing more about providing more tests? Why can't people get tests if they're asymptomatic? Because we know about the spread of all that and all the different issues. But the issue that you've been raising, and it's something that Carl Hennigan at Oxford University has been raising, is whether or not these tests are even worth the paper they're printed on. Last week, Matt Hancock told me that the false positive rate for these tests was below 1, and he said that was a nice low rate and that was a good thing. You're very concerned and have written a piece over the weekend to point out that he's quite wrong about that, isn't he?
Yes, good morning, Julia. Yes, I'm afraid he is completely wrong about his view that there is no problem at all. So it's important just to explain what do we mean by false positive, because I think the health sector has got the wrong definition. The real definition of false positive is what percentage of the entire population that you are sampling in pillar 2 screening, what percentage come up as positive. Now, he said it was just below 1%, and lines of evidence say we think he meant probably 0.8. There's all sorts of reasons why he meant that. So if you have 10,000 patients being screened, it's 0.8 of those, or 80, that will come up as false positive. And I think he thinks it's the percentage positive.
Now, Mike, apologies. We've got a little bit of a problem. Mike, can I stop you a second, because we've got a bit of a problem with your line. We've got a little bit of a cutting in and out. But I say, let's go over the key point here is that the impression you got from the interview we did with Matt Hancock was that he thought that because the false positive rate is below 1%, that means that below 1% of the cases that come up positive are false. And you're saying, no, it's not. It's 1% of all those who you test, or 0.8% probably of who you test. And given that we have such a tiny number of people who are testing positive, around the same numbers, it means that something like in the region of 9 out of 10 of the tests that are coming up positive, people are told you have COVID, may not actually have COVID at all.
Yes, you've said it exactly correctly. So another way to say it is, if the false positive rate, the fraction of your tests that come up positive, though they do not have the virus, if that's greater than what's called the prevalence, the fraction of people who've got the virus, it doesn't matter how hard you try, and you can't subtract it, you will end up with most of your positives being what are called false positives. They don't have the virus, they're not sick, they won't get sick, they're not contagious. And you may have noticed, Julia, and that's possibly why I was thinking about this over the last few weeks. Have you noticed that when we get so-called surges or peaks, Leicester and so on, almost no one was ill, and that figures now, because I think between 5 times and 10 times the number of only 1/5 or 1/10 actually had the virus. These are the ones that are true positives. And so the problem is, if the false positive rate is higher than the prevalence, you cannot use the assay. There's nothing you can do to fix it. And I believe this. Let me just finish this one sentence. It may sound controversial, but unless they can fix this assay, I believe they should stop pillar 2 testing, because there isn't an assay that can do other than I have described to generate mostly false positives.
So this isn't that, this is a peculiarly poor test. It's just this kind of testing in the community. And this is the big difference between testing in hospital and testing in the community. Testing in hospital, we call pillar 1 testing. In the community, pillar 2. Now, when you're doing pillar 1, you're testing people who are already ill. They've got symptoms, and you're doing testing with medical professionals taking the test, and they're going straight to the lab. And that, of course, has a much higher rate of reliability than a test done by non-medically trained people in the community, of, to a certain extent, a fairly random sample of people, because a lot of people are going to get tested who haven't got symptoms themselves. They may think they've been in contact with someone who thinks they've got COVID. Again, odds are they haven't got it. So it's the number of people and the reason why they're being tested that's also the issue.
Yes, you said it right. So the pillar 1 test in hospital, certainly just to take us back to that ghastly month of March, where we were at the peak of infections, and then in April, about April 10th, we saw the peak of deaths, and then for the last 6 months, it's fallen continuously. But back in March, I've looked at the data, and fully 30% of the people who were sampled were positive. So now it's 30% who are positive, and then 0.8% who are false positive. Basically, the effect there is, instead of 30 out of 100 being positive, and they do have the virus, you get 31. There's that one. So you can see now the effect of false positives is irrelevant.
Yeah.
But now, when there's almost no one who's got it, an average member of the public, ONS says it's about 0.1%, 1 in 1,000. 0.8% is this fixed false positive rate. It's generating 5 to 10 times more false positives than real ones. And earlier in the summer, it was 20 times. So it's got to stop. They must not use this assay. It's producing catastrophizing. And also an important point, Julie, if I was right and the government said, you know, Mike Yeadon's right, Carl Hennigan's right, let's just pull this test. There's nothing else actually happening of any great note. Yes, there are some in hospital. Yes, there are some dying. But as compared with the thousands dying every day, we're down to about 1% of that. And there actually isn't any fear that the government could provide. So it crosses my mind. I don't know why. I'm not making a conspiracy, but if they wanted us to be fearful, the best way to do it is carry on using a test that produces mostly false positives, because wherever they travel, that's what they'll get.
And this is the thing, and the more testing you do, the more false positives you'll get. In fact, you'll make it more likely there will be more. But with 3,899 cases yesterday, we've been around that 3,000 mark, now the 4,000 mark. The number is going up. But we do know that the proportion of positive cases of those tested is also going up. So there is a greater incidence, we think, of the virus in the community, and we have seen hospitalizations go up and we have seen deaths go up. But Professor Carl Hennigan at Oxford University was saying yesterday, and in an article and on television, that this is the normal seasonal effect of heading into September. There is a fear that we are catastrophizing normal seasonal trends. More people will die of flu, more people will die of pneumonia, more people will get colds, more people will get COVID. That doesn't necessarily mean we're entering a second wave.
Yes, absolutely. It's absolutely right. I've tried to explain to people, and if people are listening to this and want to know more of the background, it's my new article in Toby Young's Lockdown Skeptics. I'm not a lockdown skeptic the first time. I have been subsequently. I think it's a dangerous, damaging intervention that cuts across people's lives, and worse, it doesn't actually stop people catching the virus. They just get it later. So I don't think it saves a single life, but it deprives us of access to the NHS. Everybody knows that NHS access, they're trying their best, but they've been told for some reason to keep the loading of patients light. Seriously, this was my first claim, and it's true. They're keeping the loading on the NHS light, which is why you can't get the treatments and surgeries you want, because they're planning for a second wave. Julia, if you just give me 5 seconds, I just want to repeat the strong request to Matthew Hancock and to Professor Ferguson. So if you believe there's going to be a second wave, then you must have evidence for that. What is the underlying evidence that you're resting your case on? Because you seem to think there'll be one, and you're planning for it, and you're depriving us of the NHS, and you're prepared to lock us down to avoid it. But I've looked, and there's no evidence in the literature whatever. And as Carl Hennigan says, we're definitely not in a second wave at the moment. When you look at the data, honestly, there are more cases, but for the reasons Carl Hennigan said, I think at most we're in a second ripple.
Okay, thank you very much for joining us, Dr. Mike Yeadon, former Chief Scientific Advisor with Pfizer, looking at those figures. Really appreciate you joining us. Great to speak to you. 8:18 is the time. A quick word from Benjamin Butterworth, listening to all